All right, guys, welcome to part 6. Let's get into it. So I know last time I said we'd cover multiple sclerosis. I think it's a pretty high yield condition, so let's just tap out a few key points about MS. So MS is a chronic CNS condition. It's caused by autoimmune inflammation, T-cell based inflammation and demyelination of the CNS, that's the brain, the spinal cord, right? It's a disease that's spaced out over space and time, so you have lesions in different places and that are in different stages. You'll remember that MS, the myelin sheath tries to remyelinate, but it doesn't manage to fully. So that's how you get the chronic progression of the disease, because you aren't fully able to heal from these kinds of lesions. The classic patient here is a female in her 20s or 30s. Usually it's a Caucasian female from a Nordic country somewhere with low vitamin D. That's key to know. Low vitamin D levels have been associated with increased MS risk. Also, interestingly, HBV and HHV6 have an MS association with them. All right, so there's a T-cell association. Mainly it's a T-cell association, but also we have B cells jumping into the mix. So there have been some studies suggesting that B cells do play a role in MS, but the involvement's kind of unclear. We know that cells that suppress, medications that suppress B cells do work in MS in reducing the inflammation and kind of extending lifespans. So it's mainly a T-cell disorder, but the whole spectrum of the immune system does play a role. What are you going to see with this disease? So there's going to be eye findings. They love to throw eye findings on this disease. Optic neuritis is one of them. That's inflammation of the optic nerve. And what happens is you'll get blurry vision, and you also get pain, usually in the back of the eye in these patients. So a loss of vision, pain in the back of the eye, there's one of your suspects for MS. Also something called Marcus-Gunn pupil, which is an afferent defect of the pupil. So what that means is, let's say I'm swinging a flashlight in front of your eyes, and when the flashlight is right in front of your right eye, instead of constricting to accommodate for the light, it's going to dilate because the light is going away from your left eye, which is now dilating, and your right eye has lost its afferent signals. So now it's depending on whatever the left eye does, the right eye copies, if your right eye is affected, for example. I hope that made sense. So when light is shone in one eye, it's going to depend on the signal from the other rather than its own signal, because the afferents are dead in that eye. Okay. Then we have intranuclear ophthalmoplegia. This is kind of like a damage to the MLF, the medial longitudinal fasciculus. And what happens is when you look laterally, the MLF controls lateral gaze. So that's your cranial nerve 3, cranial nerve 6, activated lateral gaze. And you'll get double vision and nystagmus when the patient looks laterally. Demyelination of the spinal cord tracts causes things like spasticity. Remember, fasciculations are things that cause our upper motor neuron signs, and fasciculations are lower motor neuron signs, and spasticity is an upper motor neuron sign. So the person's going to have spasticity, hyperreflexia, all the things you'd see with kind of spinal cord lesions. Neuropathic pain is another good one. Numbness, so neuroscience from spinal cord damage, as well as brain damage. You could have cerebellar involvement, and that presents with the key 3 findings of cerebellar involvement, which is called Charcot's neurological triad. And that includes things like scanning speech, where you pause on a vowel, nystagmus, and intention tremors. Intention tremors are one of those key cerebellar findings. They'll try to trip you up, they'll try to make you think it's a stroke, but you'll definitely have something bilaterally to help you differentiate. Strokes are usually unilateral in this case, but they might have like bilateral intention tremor or something like that. Cranial nerve palsies, so diplopia, facial palsies, trigeminal neuralgia are all possible with MS. All right, autonomic dysfunctions is another one they like to throw on there. Things like bowel bladder dysfunction, impaired sexual function. All right, and the main psych thing they put in with MS is going to be depression and emotional changes. Yeah, and Lermite sign. That's another fun one that they put in there, where you have the patient bend their neck forward, and they're going to have like a shocking pain that goes down their spine. That's another demyelinating spinal cord sign with Uthoff phenomenon, Uhthoff, Uthoff phenomenon. That's reversible exacerbation when exposed to heat. So an MS patient, after they take a hot shower, they can have these MS kind of symptom spikes. So watch out for that. It's very classic when they like to test this concept. And most of the causes of most MS types, not all of them, but like 90% of them have a relapsing remitting pattern. So they get better, they get worse, they stay the same or get a little bit better, and then they get worse again. Kind of a step down sort of pattern. If you're trying to diagnose MS, you want to look for two things: the MRI findings, where you have periventricular white matter plaques that are in different stages and different sizes, and you'll also see CSF findings, where you have two things in the CSF that will tip you off. Lymphocytic pleocytosis, which basically means there are high lymphocytes. Pleocytosis means many lymphocytes in the spinal cord fluid, and oligoclonal bands. And don't let oligoclonal bands trip you up. That means that there's a IgG subfraction overproduction. So it's just going to be IgG. It's not oligoclonal in the sense that it's multiple types of antibodies. It's just multiple types of subfractions of IgG in the CSF. Okay, and you'll have myelin basic protein in the CSF as well. But they really love lymphocytic pleocytosis, and they also really love oligoclonal bands. Those are highly tested. So how do you treat MS? You have IV steroids. That's the mainstay of an exacerbation treatment. And plasmapheresis you can also do as a second line. If you want to prevent MS, here's where some of your interesting drugs come in. You have your interferon beta. That's one that's highly tested. That's going to ramp down your immune response, especially from T cells. And then you have your other things like monoclonal antibodies, natalizumab, ocrelizumab, adalimumab. Those are the three they really love to throw on there. So if we go into just a tiny bit on the mechanisms, adalimumab is a CD52 monoclonal antibody, so it's going to target the CD52, which is found on TB cells, NK cells, monocytes as well. And then we have natalizumab, which is an alpha-4 integrin inhibitor, so the T cells will not be able to get to where they want to go without integrins. And ocrelizumab is an antibody that targets CD20, and now this is more of a B cell targeting drug. Remember that it's MS is usually associated with T cells, but you have a B cell association in your arsenal as well when you're looking at why MS happens. It's still under study. There's still a little bit of mystery, so they won't throw too many crazy things at you, hopefully. You can treat spasticity and tremors with things like dantrolene, carbamazepine, and definitely if they're depressed, you want to start them on some kind of antidepressant. So treat the symptoms, prevent remission, treat the exacerbation with steroids. Okay, so another key thing that I think they'll test you on is tumor markers. Let's go through a couple key tumor markers and where they're found. The first one I want to talk about is AFP, alpha-fetoprotein. Alpha-fetoprotein is found in hepatocellular carcinoma, so liver cancer, yolk sac tumors, ataxia telangiectasia. You'll classically see high AFP with in utero with neural tube defects, abdominal wall defects, and low AFP. This is also in utero with trisomy 21. It's also low in the other trisomies, but they love to test trisomy 21. Okay, so that's AFP in a nutshell. HCG, it's a pregnancy marker. It's high in, it'll be high in men if they have a testicular germ cell tumor, like a choriocarcinoma or a mixed germ cell tumor. And it'll be high in women that aren't pregnant if they have things like a choriocarcinoma, which I guess they are pregnant just with a tumor. And high in things like hydatiform moles, molar pregnancies. So HCG, pregnancy marker, testicular cancer marker, choriocarcinoma marker there. CEA, carcinoembryonic antigen. This one's also colorectal. This one's colorectal and pancreatic. So GI tumors are the main ones to look out for with CEA. It's also elevated in people who are smokers, pancreatitis. Those can be found even in non-cancer settings and elevated CEA. Prostate specific antigen, or PSA, is found in prostate cancer. It's used to trend the progression of the cancer, not necessarily to diagnose. So that's important. Calcitonin is in MEN1 and MEN2. Remember, that's medullary thyroid cancer. That's the marker there. ALK-Phos is used for bone metastases and detection of kind of bone cancers, as well as Paget's disease, which is a chronic remodeling of bone. Placental alkaline phosphatase, or I think it's PAP or PLP, is found in seminomas and in smokers. Basically, there's some controversy with placental alkaline phosphatase, so I really don't think they'll use it much in question stems, but it's there just for you to know. Lactate dehydrogenase, you'll definitely find it with high tumor burden, because tumors are mostly anaerobic metabolizers, and you'll see it in things like dysgerminomas. Testicular germ cell tumors love high lactate levels. Neuron-specific enolase, this is a good one because it's found in the neuroendocrine tumor types. So that's small cell lung cancer, carcinoid, neuroblastoma. These are all neuroendocrine, and they really love testing small cell lung cancer. You'll get things like high PTH, things like ADH, SIADH with small cell lung cancer. So watch out for the neuroendocrine aspects. I think, maybe in the next episode we can cover some neuroendocrine stuff. All right, so CA19-9 is pancreatic. I think everybody knows and is comfortable with that at least. And S100 is going to be malignant melanoma. Chromogranin A is another neuroendocrine marker on top of neuron-specific enolase, so they like to pair those two together. Monoclonal immunoglobulins are seen in things like MGUS and multiple myeloma. And I think those are the main ones to go through and know. So I think we've done a pretty decent, kind of quick, thorough job on that. All right, so the next thing I want to talk about a little bit is diuretics. I think we all use diuretics every day in residency, and because we don't usually go back to the basic science, it's easy to forget how the diuretics work, what kind of side effects they have. It's a super busy time in residency, so even I sometimes, I find myself forgetting sometimes how certain medications work, and I have to go look it up. Or if I'm too busy to look it up, I'll just trust what UpToDate says. So let's just go through and talk about some of the diuretic types, how they work, and what are the common side effects, just as a refresher. Hydrochlorothiazide, or the thiazides, they're really three main thiazides you should know: HCTZ, chlorthalidone, and metolazone. Now they'll give metolazone on test because it doesn't have that TH tip off, and it's not as common, so they really want to test your memory skills there. So how thiazides work is they inhibit the sodium chloride cotransporter in the distal convoluted tubule, and so now sodium and chloride are stuck in the tubule, and they get excreted, peed out along with water that follows the solute. So when the sodium is, sodium and chloride is built up in the tube, there's going to be a couple side effects of this. One of them is that you have increased reabsorption of calcium, because the sodium calcium counter transporter, I think it is, on the basal side of the membrane is not working anymore, so you're not going to get calcium going into the urine because sodium's not coming to compensate on the way back into the blood. Okay, so high calcium is one. Low potassium, because the sodium that's now moving down the tubule, the sodium potassium exchanger, is working, but it's the sodium is now exchanging for potassium with the sodium potassium exchanger, and you're going to get peeing out of potassium as well. So sodium likes to pull out potassium with it because of this counter transporter in the distal tubule. Okay, so low sodium, low potassium, high calcium. You'll also have low magnesium. The mechanism for some of these is not entirely elucidated, but yeah, just remember sodium, potassium, magnesium like to hang out together, so those three will be low. Now, if we go into some of the higher things, we have high calcium, like we talked about, high sugars. That's one thing that some people don't really focus on, is that thiazide diuretics can increase someone's sugars. How it works is that they decrease insulin release, and therefore they decrease glucose uptake into the bloodstream. So insulin is if it's going to be decreased, and then you're going to have high blood sugar. You'll also have hyperlipidemia or high triglycerides. So you really want to kind of avoid thiazide diuretics in someone with metabolic syndrome or high cholesterol to do in the first place, because you'll only make it worse. So high glycemic, high lipids, don't do it. Hyperuricemia, you'll get high uric acid in the blood. So also avoid it in someone with gout, because these thiazides help to reabsorb uric acid. So main things to watch out for there: low potassium, low sodium, low magnesium, high calcium. So if the person already has high calcium, I would avoid it. High sugars, high triglycerides, and high uric acid. Okay, so those are the key things I think to know about with thiazides. Okay, the acronym there, I think if you need an acronym, is GLUC, G-L-U-K-C, which is hyperglycemia, lipidemia, and uricemia. That's how you remember the hyper parts of thiazides. Alright, so and remember, you want to avoid thiazides with people who have gout, people who are in metabolic syndrome, people who have already low potassium. You don't want to exacerbate any kind of metabolic abnormalities that already exist. Alright, next let's move on to loop diuretics. These loop diuretics are also sulfonamides, so if the person has a sulfa drug allergy or insensitivity for any reason, watch out for loop diuretics. That usually is going to encompass your furosemide, torsemide, bumethidine, and ethacrynic acid. And they like to test, they know furosemide's a loop diuretic and torsemide, but do you know bumetanide, and ethacrynic acid? Bumetanide and ethacrynic acid, I bet, are the ones they like to throw at you at the test, just to try to trip you up. So how these work is they block the sodium potassium 2 chloride channel transporter in the thick ascending loop of Henle, and you have essentially those solutes trapped in the lumen, and they pull water when they get peed out. All right, and just like with thiazides, you have unlike with thiazides, you have decreased reabsorption of potassium and calcium and magnesium. I'm not entirely sure on how that the calcium theory works here, or the magnesium, but I guess just memorize them for now until we have a podcast where we have time to go into the mechanisms. So calcium and magnesium are the two important electrolytes for loop diuretics. All right, and side effects for loops include ototoxicity, so it can cause hearing problems, it can cause nephritis, um, induced medication-induced nephritis, allergic nephritis, things like that. You can have rapid dehydration, where you can have pre-renal kind of damage there, and I think those are the main side effects for loops. Watch out for people with calcium, and watch out for people with magnesium deficits. Okay. All right. Also, there will be some hypokalemia in loop diuretic usage, so I would not use it in someone with hypokalemia, hypomagnesemia, or hypocalcemia. Let's throw potassium in there as well. All right. Be wary of those three electrolytes. We'll go through an electrolyte review after we've gone through all of them, just as a quick refresher. Okay. Next, we have potassium-sparing diuretics. Usually, you can combine these potassium-sparing diuretics with a thiazide, for example, so that you kind of help to preserve the electrolyte balance in someone's system. They're usually pretty good at maintaining potassium levels at baseline. All right, so it's getting late. So let's talk about the two types. There's aldosterone receptor antagonists like spironolactone and eplerenone, and there's ENaC channel blockers like triamterene and amiloride. So they all spell out conveniently if you want to remember the acronym STAKE: spironolactone, triamterene, eplerenone, amiloride, and these are K sparing, so that completes the acronym. And aldosterone is the hormone that kind of facilitates reabsorption of sodium and kicking out potassium in its place. So these aldosterone antagonists, spironolactone and eplerenone, they're going to stop that receptor from acting, and therefore they will preserve your potassium. All right, so another thing to look out for with the side effects of these potassium-sparing diuretics is that instead of essentially stopping aldosterone binding, they competitively bind for aldosterone spot in the distal convoluted tubule, and they inhibit the effects of aldosterone, decrease sodium reabsorption, and also decrease potassium excretion. So you're peeing out sodium, which is how you get the diuretic effect, but you're retaining your potassium at the same time. Okay, and another thing to remember is that hyperaldosteronism is seen in PCOS, so these are great for people with PCOS. Okay, and the contraindications for potassium-sparing diuretics is if they already have hyperkalemia, obviously, and patients with hypertension with a contraindication too, with concomitant essentially diabetes mellitus and microalbuminuria. These diuretics can exacerbate that, so I would avoid them in that case. So don't avoid them in diabetic nephropathy. I would much more stick with an ACE in that case. ACE in that case. All right. And then we have things like osmotic diuretics, like mannitol and urea, but these are not really commonly used because we have such better options, and you can use them for other cases. Like, for example, mannitol is used in elevated intracranial pressure, used in acute glaucoma, so it's used with high pressure in other areas than the blood pressure. So you want to avoid these kind of diuretics if the person's obviously not making urine, or if they have heart failure, because you can throw them into exacerbation. If you reduce circulating blood and heart failure, you're going to put a lot of stress on the heart that isn't necessarily good for the heart. The final class I want to talk to you about is also less used. It's acetazolamide. It's the carbonic anhydrase inhibitors. When you inhibit carbonic anhydrase, you essentially increase hydrogen reabsorption by inhibiting the sodium hydrogen exchanger, and that in turn increases sodium bicarbonate diuresis and bicarbonate elimination. So you're acidosing the person, and these are great for if you're like a mountain climber and you're up in a high mountain, you're undergoing kind of a respiratory alkalosis. That's where acetazolamide is really used to acidify yourself a little bit and maintain your pH balance. You can also use it in acute glaucoma, and as we talked about, the main use is altitude sickness from respiratory alkalosis. Acetazolamide causes acidosis, so ACAC. That's a good little mnemonic to remember that. Okay, so I think we've covered a good chunk of stuff today. We'll cover some other interesting topics in our session tomorrow, and hopefully you got a little bit out of this, at least a little bit of memory refresher on what we learned about throughout these podcasts. I hope these are helpful. I hope they're helping you. I know they're helping me do a quick review every night, so we'll see how it goes. I look to continue these for as long as I can, and if anyone has any suggestions or ways to improve them, things that they would like, for example, in the format, I'm open to that. Just drop a comment and I'll make sure to read them all. All right, thanks, and I'll see you in the next one.